A lot of the questions from the audience have to do with treatments and with risk factors. Let's talk about risk factors. Right now, obviously, there seem to be some risk factors for developing long COVID, but again, as you said before, it's more than one disease. The way I look at the literature is, look, the biggest risk factor for long COVID is how sick you were at first. Really sick people early on, especially pre-vaccine, pre-immunity. The risks of having symptoms 3, 6, 9 months later were a lot higher. Um, uh, Beyond that, what do we know about risk factors?
Sure. For that, I really like always the devil is in the details. So I like to classify long COVID into maybe two types. The prototypical long COVID, the fatigue, brain fog, post-exertional malaise parts. So those tend to happen, more in females, in younger people than older adults, and so that's sort of the prototypical type of long COVID. And there is sort of the other types that involve kidney dysfunction, new onset diabetes, heart disease, strokes. Those are actually happening in older adults in the post-acute phase of the disease, and in people who have existing comorbidities or existing risk factors for those diseases, for heart attacks, et cetera, et cetera, et cetera. But having said that, I think the one unifying thread, for all of this, and actually in almost all the literature that you read, is exactly what you just told the audience, that severity of acute disease really, really matters. That the more severe the disease in the acute phase, if it's required hospitalization or even worse, required ICU stay, those people tend to be at the highest risk of post-viral problems. That does not mean at all. I don't want to take the audience to take it, that doesn't mean that mild disease cannot lead to long COVID. As a matter of fact, more than 90% of people with long COVID in the world have had mild disease, just because most people in the world had actually mild disease. Most people in humanity,
It's a base rate. It's a base rate.
Exactly.
Yeah.
Yeah.
One thing that I struggle with is a lot of, I mean, I'm like middle age, right? I'm not young. I don't think I'm
You're
old, but
young.
like, but like people come to me in their 30s and they say, oh, this is a long COVID is a vascular disease, right? And I just got COVID. Should I be on blood thinners because I'm a 35-year-old who just got COVID? Because, look at the clot. That paper from the VA said they got clots. And I'm like, no, 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 no. I promise you, you don't need to be on blood thinners, even though people in that risk cohort do need to be on blood thinners for a number of reasons, right? I mean, do you worry that people read like a VA paper and their eyes bug out and they're prescribing things to 25-year-olds who are essentially, look, they could get long COVID, and I think we should be giving them treatments if we can find them, but they might be over treating them.
Yeah, I mean this is very, very important. So always like risk versus benefit, right? So especially I see people on triple anticoagulation for no indication really. I mean, there's really buying all the risk and there's really no benefits. I think what complicates long COVID treatment is that we don't really have enough trials to really help us understand what works and what doesn't, and also evaluate the risk benefit. So I'm very familiar with the sort of the push to use anticoagulants in the setting, because the presumed thing that is endotheliitis, they're more prone to clotting, which is true. That definitely there is clotting, macroclotting and microclotting in the setting of long COVID. But I think we need to be careful about treatment, especially those ones that could be associated with significant side effects, like anticoagulants. They're absolutely not free of side effects, and some side effect could be catastrophic. People could have bleed, like hemorrhagic strokes, and even die from. I mean, these are not sort of these are serious side effects. So I think we need to be careful about treatment and not sort of generalize, sort of defining from one study to extrapolate that we need to all be on anticoagulants just
Right.
because we got with SARS-CoV-2. That definitely
And
not.
I do think that people do underestimate like the risks of some things, which is, by the way, like why I thought metformin is like such a positive development. This is a medication that is very well tolerated, has very low risks. I can count on one finger the number of metformin associated lactic acidosis cases I've seen in my life, and really it's just an overdose. Versus patients who I see who were on blood thinners because they're kind of on the borderline for indications for other reasons. They come in, they fell down the stairs, and now they've got a subdural hematoma. So I see there's a big, but I don't think the public always necessarily understands like the severity of risk in some of these drugs. Another thing that comes up a lot is the unknown. the big question is Paxlovid, right? I mean, I think that Paxlovid is an important medication for high risk people in the acute phase. Um, for long COVID, though, I don't think it's played out yet, and I don't know yet. And look, I've done some research that shows maybe a signal, but I'm pretty skeptical, even though I'm involved with that. And I actually don't know if we know, we don't really know whether it's causing rebound or whether that's background. Where do you stand right now on Paxlovid research with long COVID?
So there are two things. I think Paxlovid in the acute phase, and people who qualify for Paxlovid, basically they have to have risk factor for progression to severe COVID-19 illness. I think taking it is definitely better than not taking it, so better than placebo. It reduces the risk of hospitalization, of death in the acute phase, and might reduce the risk of long COVID. That's when you take it in the acute phase. Now, Paxlovid used in the post-acute. Let's say somebody already got COVID and maybe have long COVID, and then they're there is no evidence, as you know, there is no trials in that space, and the presumption there is that there is viral persistence and the virus is replicating for Paxlovid to work. Like how does Paxlovid work? So for the audience, actually blocks viral replication. So if there is no virus that is persisting and it's actually not replicating, Paxlovid is unlikely to have any material effect or material benefit. So the presumption there is that in those cases, there is a virus that is persisting and is actually, that is replicating. There's not a whole lot of empiric evidence for that. And that doesn't mean that a virus, a remnant of the virus, like RNA or protein, cannot be persistent or persistently present in quote unquote immune privileged sites that are provoking chronic inflammation and subsequent sequela. But Paxlovid is not going to do anything for remnant RNA. If it's not replicating, Paxlovid blocks replication. It's not going to do anything for RNA just sitting in a lymph node that is doing nothing,
It's more
right?
like a bee sting, right? Like the way I think about it is like if you have a bee sting, and you're allergic to bee stings, you're gonna keep having that anaphylaxis until the bee sting is removed. It's not replicating. It's just the presence of it is what's causing the immune system to go crazy. And so by extension, something is left over that's not replicating, but that's the hypothesis, and so that an antiviral would be kind of irrelevant.
Correct. So, but that needs to be tested. I mean, like all science, we would need to be tested. We need to see the pro and con argument, or like for or against it, need to be tested. So we would need data to sort of help us evaluate whether that this thinking is correct or not. But the only way to solve is actually we need those trials to come out, and more than one of them, obviously, to sort of help elevate our confidence that this is really the right answer, that Paxlovid really works or not. I think for it to work again, the virus has to be replicating, has to be present and replicating like months after the acute illness, right? And there is very, very little evidence to convince me of that. But I'm a scientist. I'm learning all the time.
Yeah, and so we've got good news on the metformin on the prevention side. The Stanford Paxlovid study was stopped. We don't exactly know why. We also know that at Yale they're doing this decentralized study of Paxlovid.
Yes.
What else are you looking at in 2024? Studies coming down. Where's your sort of like lens? Like, oh, I can't wait for this study, or what data are you waiting for right now?
So there is a lot of people who are sort of interested in actually more antivirals. There is other than Paxlovid. And again, those will only likely work if that viral persistent hypothesis is actually really true and the virus is replicating. People are actually trying low dose naloxone and naltrexone to try to sort of see if those may ameliorate symptoms. There was some interest in also resuscitate or thinking about SSRIs. There was a paper not long ago in Cell sort of suggested that intestinal absorption of tryptophan, the precursor for serotonin, is impaired, and subsequently low level of serotonin in the blood, and that sort of might impair serotonin vagal nerve signaling and impair cognition, sort of explaining some of the brain fog and maybe the autonomic dysfunction that can happen in people with long COVID. So whether serotonin replacement like SSRIs would be helpful, I don't really know, but that also is being thought about as a potential therapeutic avenue. And there is I'm aware of at least a couple applications sort of thinking about actually low dose anticoagulants. Again, the risk and benefit need to be evaluated, and the only way to know is to do the science to sort of evaluate the benefit and evaluate the risk and determine if actually indeed very careful low-dose anticoagulants really might ameliorate symptoms or symptomatology. But I have to say that I'm glad you asked this question. In my view, the world of trials on long COVID is really thin. I pretty much just reviewed everything that's going on in the U.S. There is a microbiome study. There are some microbiome studies in Hong Kong. But there need to be more. There need to be more. And most of these trials are actually also, small and may not yield really definitive answer. And I think that sort of calls for hopefully more energy and more enthusiasm and more resources in the space to do trials that are commensurate with the problem. Like long COVID, I think is a big problem, and we need to solve it. And hopefully we can solve it earlier than later. And the only way to really discover treatment is to do trials, and the scale of those trials need to match the magnitude of the problem.